Now being recorded. Good morning, everyone. Happy New Year. Welcome back from the holidays to our first rounds of the 2025. Hope people had a nice break. A lot of us have seen each other in other settings, but this is our first rounds in 2025. So welcome to everyone. Wishing everyone a happy and especially healthy New Year 2025 and fun for all of us. Let me do a few quick announcements in terms of upcoming HIV Center activities. We have on February 6th, it's during our usual rounds times, but it's kind of a special, little bit of a different format. It's a workshop from our own people internally to the HIV Center, Doctors Justin Knox, Amy Campbell, and Jennifer Moots. And they're following up on their 2024 Implementation Science Workshop. So this is part 2 of that workshop entitled Real World Applications of Implementation Science in HIV Research from Curiosity to Practice. So good title, I think, and it should be a really, really good workshop. So please come in for that. Chris, is that in person? It's a hybrid? It's a hybrid event, so please, people, try and come in person for that. I think that's especially good for workshops because it'll be interactive. And then I'll mention our other rounds in February 20th. We have Dr. Victoria Fry from Columbia School of Social Work. We don't have her title yet. She's still working on that, but it will center around her research on HIV prevention among women in Kazakhstan. So today we have a very special guest and a very special co-sponsored activity rounds from the HIV Center and from the LGBTQ+ program in our Division of Gender, Sexuality, and Health. So it's being sponsored by both programs in our division. And I'm going to invite Walter Bochting to introduce the speaker for today.
Thank you so much, Bob, and still a happy new year, everyone. And thank you all for also coming here in person, for those of you who are were able to make it in person. And I see that some people have, I think, especially come out for our speaker today. So maybe towards the end, we can mingle a little bit, have some introductions. I think that would be nice. So it is my great pleasure to introduce Dr. Ayden Scheim. And I feel, I've known Ayden for a long time. I kind of feel that I've seen him grow up. And I think grown up, he really has, if you really look at your accomplishments and where you are at now, it's just fantastic to have seen that, to have seen you rise and to also see all the energy, that you have and putting into the field to make this world a better place for the people that we care about. So you do have the bio in the announcement. So I'm just going to read it to you. But then if you want to look things up, you can still find the details there. So Ayden is a social epidemiologist and who works with populations confronting stigma and oppression to understand and address the health impacts of inequitable social, policy, and healthcare environments. He conducts community-engaged research with LGBT communities and people who use drugs, as well as methodological research on measuring intersectional social positions and intersecting forms of discrimination. Currently, Ayden leads a community-based participatory research service with trans and non-binary people in India and Canada, funded by the National Institute of Health and the Canadian Institutes of Health Research. He is also PI of 3 studies funded by the National Institute on Minority Health and Health Disparities that seek to improve the measurement of intersecting forms of interpersonal and structural stigma and discrimination. So I think very timely, intersectionality is also a big topic, one of the priorities in our division. And, measurement, especially quantitatively, I think is really a challenge. So we hope to learn about that. So Dr. Scheim holds adjunct appointments in the Center on Drug Policy Evaluation at St. Michael's Hospital in Toronto, Canada, and in the Department of Epidemiology and Biostatistics at Western University in London, Canada. And he's also a visiting professor in the Center for AIDS Prevention Studies at UC San Francisco. So he received his PhD in epidemiology and biostatistics from Western University in Canada, where he was the Pierre Elliott Trudeau Foundation and Vanier, I'm not sure if I'm pronouncing it correctly, Vanier Canada Graduate Scholar, and completed postdoctoral training at the University of California, San Diego, as a Canadian Institute of Health Research Fellow. So now an independent investigator. Let's welcome our guest, Dr. Ayden Scheim. Come on up.
Thank you so much for the warm welcome and for not sharing any stories about anything that might have happened in my youth when you must have met me. Yeah, it's not that I'm so old, it's that I started so young, just to clarify. Oh, yes, please. The short people adjustment. Thank you.
What was there, right?
And fair warning in advance, I had a cold last week. I have recovered. The only thing that is not recovered is my voice, so I have hot tea with me. But if at any point I start to sound funny, bear with me, please. It's a pleasure to be with you today to speak about intersectional approaches to measurement for social and behavioral HIV research. I think this dovetails really nicely with one of the talks I saw that happened just before the break by my colleague, Steph Morale. He had a lot of data in his talk. I'm going to have fairly little data in my talk for an epidemiologist, really focusing more on conceptual and theoretical issues today. I will give you some data, but really more kind of as proof of concept. So specifically, I'm going to start by talking about some overarching principles to doing quantitative intersectionality research. I'll then talk about intersectional approaches to measurement. Spend a little bit of time on the measures that I co-developed and that I'm continuing to evaluate in some current NIH-funded work, and then talk about next steps and future directions for my team's work. And leave time, of course, for conversation at the end. I'm sure most of you have seen this definition of intersectionality, but I want to begin ensuring that we're on the same page conceptually. There are many definitions. I really like this one from Lisa Boleg's 2012 article in AJPH, where she defines intersectionality as a theoretical framework which posits that multiple social categories, such as race and gender, intersect at the micro level of individual experience to reflect multiple interlocking systems of privilege and oppression at the macro social structural level, such as racism and sexism. What I like about this definition is that it emphasizes that intersectionality is not only about social categories or identities at the individual level, but rather about systems of oppression at the structural level. Of course, intersectionality goes much farther back than this 2012 article. The term itself was coined by Kimberly Crenshaw in her 1989 legal review article, but you can see ideas of intersectionality much farther back in Black feminist theory and women of color scholarship. Early examples being Sojourner Truth's Ain't I a Woman's speech, the Combahee River Collective statement, which was a Black feminist organizing group in the late 1970s, in the work of Patricia Hill Collins, and many others. And intersectionality has been described as a traveling theory that has moved from its origins in Black feminist theory, in critical race theory, to the health and social sciences. And that travel comes with a lot of opportunities, and I think has really enriched our work as HIV researchers. And it also comes with risks. One of those risks being that we flatten what is a very nuanced framework, and a framework that is not only about research, but also about action, and risks that we only pay attention to what has been more recently published or the things that we normally read in our disciplines. So I think a great example of this, there's a photo image here of a recent editorial by Michelle Tracy Berger. Michelle Tracy Berger is the person who coined the term intersectional stigma in her book, Workable Sisterhoods on Activism of Women Living with HIV. This editorial is from the recent AJPH special issue on HIV-related intersectional stigma. And in it, she talks about how surprised she was to learn that intersectional stigma was the organizing principle for special issues of journals, for NIH funding calls, so on and so forth, but nobody was citing her book. And I think part of that is that many of us in health sciences don't actually read books after grad school. That's part of it. Part of it is systemic problems with underciting, undercrediting of Black women for their work. But I think it's really important that we read and cite books if we are going to seriously engage with the richness of intersectionality. And you can see some of the challenges in sort of deeply reading and then deeply integrating principles of intersectionality in quantitative health research when you look at some of what has been published under the umbrella of quantitative intersectionality research. On the right side of this figure, of this slide, is a figure from a really great Public Health Agency of Canada resource on integrating intersectionality theory in quantitative health equity analysis. And they looked across 34 studies at how well different principles of intersectionality were integrated in the rationale, in the analytic design, and in the interpretation. And what you can see is that, and if I can, for those in the room, if I move this, you'll see even more. There we go. That the principles that were least integrated in the publications they looked at were reflexivity, so critical reflection on one's social location and how that influences their approach to the work, and integration of diverse knowledges. And I think as people trained in quantitative health and social sciences, those are probably some of the things we're least trained to do. So again, really calling us to think about what we need to do long before we think about how to measure things, before we even begin studies taking an intersectional lens, some of the work we need to do to fill in the gaps in our own training. And on the left here, I'm just pointing out another set of core principles of intersectionality as outlined by Patricia Hill Collins in a book that I also think everyone should read, Intersectionality is Critical Social Theory. Here you can see just the remarkable growth in quantitative intersectionality publications, beginning really in the mid-2010s. This is from a systematic review led by my colleague Greta Bauer in Social Science and Medicine, Population Health. Huge increase in publications, but when they dug a little bit deeper into how those articles were actually engaging with intersectionality, it's a bit of a mixed picture. So for example, a quarter of studies didn't define intersectionality. About a third didn't cite any foundational authors, and there was limited engagement with methodology papers. So great that there's interest in integrating intersectionality, but there's definitely room for us to be doing it, I think, more deeply. And related to that, I'll point to some guidelines that we put out way back in 2014, but that I think are still relevant today. A group led by Greta Bauer, Lisa Boleg, that I was involved in, put these guidelines out. And one of the first things we said, and I think what I just showed speaks to this, is the need to avoid simply using intersectionality as a buzzword in our research, but to engage more deeply with the underlying theory. Some of the other guidelines we put forward that I think are relevant as we start thinking about measurement are to decide on intersections of focus in advance and engage relevant communities at all stages of the research. That said, there might be exceptions to that. So for example, it's perfectly reasonable to take an exploratory data-driven approach in some cases. And in that case, you might not be able to identify the intersections that are relevant until after you've done the analysis, but you can still engage communities in the interpretation. Another point we made that will be a recurrent theme today is being clear about what exactly is intersecting in your intersectional analysis. So as I mentioned before, we often get stuck at the point of thinking about intersecting identities. And sometimes it's perfectly reasonable for people's self-identified categories to be the unit of analysis for us, but we need to keep in mind that those are always proxies. How someone identifies is a cause of very little in terms of health. Where really, these identities are proxies for the social forces that people are exposed to. We also might be interested in intersecting social locations or positions. So for example, social class is something that is not generally a strongly held identity in this country, but is obviously an important axis of social power. We might be interested in intersecting social processes. So for example, racism and sexism, intersecting social contexts, neighborhood contexts, for example, or intersecting sets of policies. We also want to consider the pros and cons of focusing only on multiply marginalized groups versus including comparators. Sometimes it makes sense to focus specifically on a multiply marginalized group because you might be interested in an experience that is unique to that group. There's also tension around continually reifying social hierarchies by always comparing marginalized people to members of dominant groups. And on the other hand, if we're interested in addressing intersectional health inequities, when we don't include comparators, we might get what Sharon Schwartz has called the right answer to the wrong question, because the causes of variation between groups are not necessarily the same as the causes of variation between groups. So keeping those tensions in mind in relation to the questions we want to answer. And of course, thinking about issues of sample size, and whether the measures that are included in our study are actually appropriate for all of the different social categories we're aiming to address. Related to what I just said about the pros and cons of focusing on multiply marginalized groups versus including comparators, you may be familiar with this typology from Leslie McCall's 2005 article, which I find really useful. In my work, it's a typology, so it's necessarily a simplification, but still can be really helpful. So she outlines these three approaches. First, anti-categorical. This is an approach that argues that social categories create difference and thus reinforce inequality. And you might at first glance think that that's really incompatible with quantitative research, but there are people doing work that is quantitative and that takes an anti-categorical approach. So for example, people using an approach called multi-level analysis of individual heterogeneity and discriminatory accuracy, MIDA for short, which among other things, uses discriminatory accuracy methods to ask, to what extent is intersectional group membership actually differentiate between those with and without an outcome of interest. Intra-categorical approaches then focus on experiences at specific and generally neglected or marginalized intersections of social categories, whereas intercategorical approaches look at relationships of inequality across intersecting social categories, still taking seriously the critique that these categories are socially constructed, but that they reflect real differences in power. Put another way, the difference between an intra and an intercategorical approach is that the former might focus on multiple social categories, for example, race, gender, disability, but is focusing on one dimension of each of those categories. Let's say Asian women living with disabilities, whereas an intercategorical approach would be making comparisons across multiple dimensions of race, gender, and disability. And then in my work with Greta Bauer, we've also outlined this distinction in intercategorical work, which as a population health researcher is where my work is situated, between descriptive and analytic approaches. So a lot of the work that's been done on intercategorical intersectionality has been about describing health disparities across intersecting social categories. And that's a really important first step, but it is a first step because it doesn't tell us anything about how to actually change those inequities. And thinking about the social justice aims of intersectionality, we think it's imperative that we, as much as possible, also focus on understanding the mechanisms that drive those inequalities so that we can reduce or eliminate them. And then finally, if you'll indulge me in one more piece of definitional work before I talk about measurement, I want to ask a question about what intersectional stigma is. So As I mentioned, Tracy Michelle Berger defined intersectional stigma as the synchronistic influence of various forms of oppression that combine and overlap to form a distinct positionality. And not to single out NIMH here, but you can see kind of the flattening and watering down that I mentioned in the traveling of that definition to then be intersectional stigma examines the juncture of multiple stigmatized identities. The figure on the right here is from Lisa Bolig's Intersectionality Training Institute, and I can't read it from there, but if you go to the website, you'll see that it makes the point very clearly that intersectionality is not just about stigmatized identities. And in her editorial in the recent AJPH special issue on intersectional stigma, she makes a really nice argument about how the way that we've used that term within the HIV research space can sometimes obscure active discrimination, the role of stigmatizers, and the role of social structural systems. So some things for us to keep in mind to ensure that we are not losing core principles of intersectionality as we conduct intersectional stigma research. So now I will actually talk about measurement. I mentioned earlier this question of what is intersecting. And I think I mentioned that we might think about intersecting processes, contexts, and policies. And in the context of HIV research, that's where a lot of the measurement work has happened. But careful measurement of social identity and position, I think, is equally important, and I don't think something that we pay a lot of attention to in HIV research. There's great work on thinking in more complex ways about, for example, racial identification in a lot of social science literature. This figure here is from an article by Wendy Roth, in which she outlines different dimensions of racial identification. In HIV research, what we most often, if you're thinking about race, what we most often are measuring is expressed race, the race you say you are to others. You know, what is your race? Choose one of the options from this list. But there are other ways we could be thinking about measuring race that get at ascribed race, the race that other people think you are. And if we're thinking about discrimination, that's actually arguably what matters, is the race that people think you are. Nancy Lopez has a body of work on this concept of street race. If someone on the street who you didn't know encountered you, what race would they think you are? And those are measures that we could be using in our work. Think beyond thinking about self-identified and ascribed categories. There's also some really interesting work on this idea of infra-categorical characteristics. I've read this article like 5 times and I insist that everybody read it. So I'm going to encourage you to read it too, by Ellis Monk, in which he puts forward this idea of an infra-categorical model of inequality that shifts focus from what he calls state categories. The best example of state categories would be those OMB classifications of race and ethnicity, to thinking about cues of category membership in subcategories, and perceived typicality as a member of one's group, and how those influence inequalities between groups as well as within groups. And that might sound very abstract, but let me show you some examples of how those kind of measures can actually be integrated in practice. To do so, I'll draw on a few examples from a study called TransPulse Canada, which is was a national community-based participatory research study of trans and non-binary health in Canada. The study took an explicitly intersectional approach. We worked with 9 priority populations within trans and non-binary communities, where we identified specific policy-related data needs. Those included youth, older adults, sex workers, people of color, Indigenous people, people with disabilities, and a few others. And we worked with each of those groups first to develop survey modules that were specific to those communities. So taking an intra-categorical approach, for example, measures about people's experiences accessing services for immigrants and refugees as trans or non-binary people. But we also worked with those groups to identify questions that would be used to code or classify that group for analyses, and questions that would get at heterogeneity within those groups, that infra-categorical complexity I was just speaking to. So for example, we asked questions about whether people identified as a person of color, but also about their ascribed racialization. So are you perceived or treated as a person of color in Canada? And those answers don't necessarily align. We asked lots of questions about disability, but also about the extent to which their disability was visible or not. And questions about how often cisgender people knew that they were trans without being told. And these questions really enabled some novel insights. I'm aware that you cannot see that figure from here if you're in the room. Very hard to show a C-tree diagram, the decision tree, and not have it be tiny. But what I'm showing here is work by a master's student at Western University, Temi Akintola, and she's building on some earlier work that we did, showing really high levels of emergency department avoidance among trans people in Ontario. And with the larger sample we had for this national study, about 2,800 people, we wanted to be able to look at intersectional inequities in emergency department avoidance. And so here we put a set of input variables into the model, and the way that C-tree works is at each stage, the algorithm identifies the strongest predictor of the outcome and splits on that predictor. So we have start with the full sample. In the full sample, identifying as disabled was the strongest predictor of emergency department avoidance. Amongst those without a disability, ever having done sex work was the strongest predictor of emergency department avoidance, whereas amongst those with the disability, being identifiably trans most or some of the time was the strongest predictor of avoidance. And so we ended up finding that the highest level of emergency department avoidance was amongst disabled participants who said that they were visibly trans. Now, in hindsight, it's kind of obvious that if you're thinking about going to an emergency room, whether you're visibly trans is going to make a huge difference in terms of your comfort accessing a place where you're interacting with strangers. But had we done a more conventional intersectional analysis based on, so-called state categories, we probably would have said, okay, let's do some intersect gender identity and race and see if that predicts emergency department avoidance. We would have totally missed these infra-categorical forms of heterogeneity that are really important as well, and things that we don't often measure. And I say we don't often measure them, but I did look for some examples of work that's thinking about this kind of infra-categorical complexity in HIV, and did want to pull out some examples. So for example, there's work around HIV stigma that thinks about visibility of HIV serostatus and how that impacts stigma experiences. Work by Theo in this room thinking about gender expression and risk of HIV acquisition. Work thinking about skin tone and colorism and how that might relate to HIV risk. So I think this is a space in which we have a lot of work to do, but a lot of really great theory that can guide that work. So I'm going to turn now to my bread and butter, which is measuring intersectional stigma and discrimination. And I get a lot of emails in my inbox asking me, I want to measure intersectional stigma. What should I use your scale? Or can I use your scale? And I always say, sure, you can, please use it. But you're going to regret asking me that because I'm going to ask you like 10 questions back. What kind of stigma, what level of stigma, what axes of stigma, what approach to intersectionality are you taking? What are your research questions? The latter should be obvious, but I think we often get into a place where everyone throws their pet measure of stigma into the survey, and then it comes time for analysis and nobody knows what to do. I get a lot of those emails too. So really helpful if we can to think about this when we're designing the survey. When I say levels of stigma, I'm thinking about whether it's internalized, felt, perceived, or anticipated, which are not actually synonymous, but I just collapsed them together for space. Enacted stigma or discrimination, or structural stigma. And this has implications for the type of approach we can take. So for example, when developing the Intersectional Discrimination Index, we initially wanted to include a measure of internalized stigma and realized that we just couldn't make it work for a cross-group measure. The content of stigmatizing attitudes about different groups was just too different for us. If someone else can do it, that's great. And then in terms of axes of stigma, are we thinking about social identities that are salient to people, things like race and gender? Are we thinking about social statuses or positions like socioeconomic status that aren't necessarily identities? Or are we thinking about stigmatized health conditions, HIV, mental health conditions, substance use, that also might be different? People might report differently based on how salient it is to them. So if we're interviewing HIV activists about experiences of HIV stigma, that might be very different than speaking to people living with mental health conditions who haven't been part of a social movement that's politicized them around those experiences of stigma. And then again, you saw this already, but thinking about what type of intersectionality we're interested in. Let me skip ahead there. There we go. So for example, if we're interested in an intra-categorical analysis, there are some really great measures that are specific to an intersection. On the other hand, if we're interested in intercategorical work, we need measures that are valid across all the social categories that we're going to include in our analysis. And I'll give some examples later of how we often don't test the assumption that the measures actually function across groups. And then thinking about the research questions we want to answer, there are a million different ways you could formulate a research question. And so this is just an example, a list of a few examples, just to make the point that not only the exact measure you want to include, but the type of measure and the number of measures you include really depends on the type of question you want to be able to answer at the end. So for example, if you're interested in just getting at the overall burden of stigma in a sample, you really need to have one measure, so you're not double counting. If you're interested in how different types of stigma interact within a group, so how do HIV stigma and racism interact, you'll need measures of both. If you're interested in the combination of specific attributions, so for example, do I think I was discriminated against because of my HIV status and because of my gender, you need to allow people to report those multiple attributions. In some of the work that I've been doing, we've been really interested in looking at stigma as a mediator of health inequalities, in which case we need to have one measure, and I'll show you actually options in which you can either have no attributions or allow people to give multiple attributions. Here's an example of an intra-categorical approach. This is an intersection-specific measure looking at microaggressions experienced by LGBTQ people of color. And then you can see that applied in this example of a study by Quinn and colleagues that with Black sexual minority individuals using a path model to look at the contribution of those LGBTQ people of color specific microaggressions, as well as more general forms of discrimination and looking at the impact on PrEP use. Another example that's also an intercategorical approach, here looking at how different axes interact, is some earlier work with some colleagues from Canada, where we asked the question of whether or not the combined effects of racism, self-reported racism and transphobia on HIV-related risk were greater than we would expect based on the individual effects of racism and transphobia. And we used parallel measures of transphobia and of racism, and found indeed that increases in transphobia and increases in racism were associated with HIV-related sexual risk only amongst people who reported high levels of both forms of discrimination. Now, I will say that this is actually an approach I don't know if I would take today, because I'm more and more of the belief that asking people to do this work of disaggregating in a survey why they were discriminated against is potentially a fool's errand. It's something we're actually investigating in our current research, so I might have a more empirical answer to that soon, but just something I think a lot about. Now, here are some examples of looking at stigma as a mediator. First, from a recent article in AJPH by Mackie Friedman and colleagues. And here they used the major discrimination scale by David Williams and colleagues. This is a two-step measure. So first it asks people questions about unfair treatment, and then if they endorse unfair treatment, it asks them why they think it happened. And in this study, they were allowed to select up to 3 reasons, and anyone who selected 2 or more reasons was considered to have experienced intersectional discrimination. And they found that they did a mediation analysis, finding that over 1/3 of the effect of being Black on what they called persistently uncontrolled biopsychosocial outcomes, which included HIV viremia, was attributable to experienced intersectional discrimination. This is the measure that they use, that major discrimination measure, is conceptually somewhat similar to the intersectional discrimination index that I'm going to move into talking about now. The difference is that our measure only has 1 stage. So it's attribution free. Rather than asking people for attributions, we use information that we collect about sociodemographic characteristics to look at the burden and impact of discrimination across groups. I think this has some, I'm biased, of course, but I think this has some advantages. The first, that it reduces participant burden, both participant burden in terms of time, but also participant burden in terms of not forcing people to do the mental gymnastics of trying to figure out, was I fired because I'm Black, because I'm gay, because I'm living with HIV, or all 3. And has some more fidelity to the intersectional principle that forms of discrimination cannot necessarily be disaggregated. And then because we don't, the measure doesn't have these attributions, in the other example I showed you, intersectionality was kind of encoded in how they define discrimination. You had to have 2 or more attributions. In the analyses that we did, intersectionality was encoded in the exposure. So we created these cross-classified groups. In our sort of proof of concept example, they were groups defined by racial or ethnic group, as well as sexual or gender minority status. And we looked at 2 things. These are complex figures, and for the sake of time, I won't walk you through them, but I'm happy to do so later if you're curious. But essentially, we asked 2 questions. First, we were looking at the relationship between these intersectional categories and psychological distress. And we asked first, are those inequalities mediated by different levels of exposure to discrimination? But then also allowing for there to be heterogeneous processes as well, we asked, are they also mediated by different effects of discrimination across the groups? Now, in that proof of concept analysis, it turns out that there was a portion of the inequality and psychological distress that was due to different levels of discrimination. We didn't find evidence that discrimination had different effects across groups, but you could think of other mediators where it might be more plausible that they would actually have different effects across groups. So to dive more deeply into what these measures look like, I already mentioned it's a cross-group discrimination measure. It includes measures of anticipated day-to-day and major discrimination, and does not require attributions. So instead, we ask people about experiences related to who they are, and you can see here how we define this. There's a 9-item anticipated discrimination scale measured on a Likert agreement scale. There's 9 items assessing day-to-day discrimination over the past year and the lifetime, and then 13 items assessing major discrimination also over the past year and over the lifetime. Back in just before we were preparing for the first term of He Who Shall Not Be Named, we conducted this validity and reliability study. It's published, you can read it, so I'm not going to belabor it, but just to say that we looked at construct validity, test-retest reliability, and psychometric analyses of the anticipated discrimination scale, found support for our validation hypotheses, and then also published that parallel paper looking at an application to intersectional mediation decomposition. A series of commentaries were published. At this time, by the way, I was on the job market for my first academic job, so this was terrifying. because I was like, they're going to say critical things about me. But in fact, one of the people who said critical things about me, who co-authored one of these commentaries, ended up now being my delightful collaborator, Jean-Louis Bastos, who is photographed there, who's at Simon Fraser University in Vancouver. He was in Brazil at the time. And he pointed out, okay, I get your argument that the enacted discrimination measures are really indices, where the items aggregate to form a construct, so factor analysis may not be appropriate. That said, if you want to do intersectional work, you need to be thinking about measurement and variance across groups, and you're going to have to do some factor analysis if you want to be able to look at measurement and variance. So started working with him. One of the first things we did is, this looks ugly because it's just a proof of a paper that's going to come out in Stigma and Health any day now, where we do subject all three of the measures to factor analysis and find good fitting unidimensional measures. So that's good news. I mentioned the idea that we need to think about the measurement and variance intersectionally. And I'll go back to the example of the everyday discrimination scale. So I'm sure you've all read research that uses the everyday discrimination scale. It's been used to measure discrimination in many racial and ethnic groups, in LGBT populations and other populations. It was developed by David Williams and colleagues for the Detroit area study, which focusing on middle-aged Black Americans in Detroit in the 90s. It is not reasonable to assume that a measure designed for a specific population, place, and time is going to be universally appropriate. And indeed, there is now some research showing that, in fact, it doesn't perform equally across racial and ethnic groups, nor across genders. That's not a problem with the measure. It's just a problem with taking the measure far beyond its initial use case. And so in our work, we've been trying to look at measurement and variance. And so the figure on the right is some work done by a master's student at Western, Rachel Gramonti, who looked at an intersectional analysis of differential item functioning of the anticipated discrimination scale. She didn't find any measurement and variance, so the results were thankfully boring, but really important to do that, because otherwise, if we're comparing scores across groups, we have no way of knowing if those comparisons are valid. And that brings me to work that is now ongoing. We're just entering year 4 of our 2-year R21. We all know how that goes. I could give a separate talk with my project manager on managing fraud in a national online study of 3,500 people. Thankfully, we figured it out when we're now at 3,100 of 3,500 people after a few very painful years. I would say that I had hair before this happened, but that's a lie. What we're doing is a bilingual study, so in English and Spanish, involving cognitive interviews and a cross-sectional survey to assess the content and wording of the measures, do more in-depth psychometric analyses, look at measurement equivalence across intersecting social positions and identities, and using a mixed methods approach to address this question of attributions, because some people really understandably pushed back on having an attribution-free measure. So we're asking from a participant perspective whether it makes a difference to them, and then we're also analytically looking at whether or not the attributions make a difference in terms of predicting health outcomes. And then we got the supplement around the same time, focused on potentially, the idea was to adapt the measures for research of people living with HIV, given that most of the people using these measures are already people doing HIV prevention and treatment work. And specifically, we were curious about whether it might be possible to modify the measures to also get at some aspects of HIV-related discrimination, thinking about the fact that we don't want to give people a million questionnaires about discrimination and wanting to have harmonized measurement as much as possible. I'll take a moment here to shout out the team working across both the parent award and the supplement, some of whom you might recognize: Greta Bauer, Tonya Potit, Valerie Earnshaw, Sinisha Dale, Jean-Louis Bastos, and Ana Maria Dario Gonzalez. We're using very similar methods as the parent award, and I'll tell you a little bit about what we found so far. We started with a modified version of the measures. We basically just changed the instructions because what you basically learn in cognitive interviews is that nobody reads the instructions. And we worked with a community advisory board at the University of Miami Center for HIV and Mental Health Research to prepare for this phase of the research. We added a part to the STEM about because of who you are or because you're a person living with HIV. We also added an item about people avoiding physical contact, which we know is a common manifestation of HIV stigma. And then we met with the CAB, and they were like, no, no, no. You are not just asking people these questions. And we made changes that have improved the project in so many ways based on their feedback. So we added a content warning. We also added a whole set of empowerment-focused questions to the questionnaire, which I'll show you in a moment. I just want to shout out this review article recently published by Carmen Logie and colleagues, really calling on us to think about better integrating empowerment-based perspectives in quantitative intersectional stigma research. And they point out a real lack of measures to do this. So we just developed some measures kind of ad hoc. We're not recommending these measures for use. It's really a proof of concept for us to see if adding these measures would help. And because we have a complex survey already, we were able to add another level of randomization where we're randomizing people to get a brief check-in about their feelings, either before or after they get those empowerment-focused questions. So we'll be able to see if they make a difference. So these are the empowerment-focused questions. I'll say that reading the answers to what is something you love about being who you are has been like very heartwarming. Also the best way to detect fraudsters. So win-win. And we then have this very brief affect check-in that they get either before or after, and we'll be able to see if those questions made a difference in how participants felt. And based on those interviews, we've done a few things. So first of all, we thought we had to call out HIV for people or they wouldn't think about it as a part of who they were. In fact, what we did when we added that to the STEM is we made them think only about HIV. And I think that's important to consider when we're recruiting people in the context of HIV research. They know the studies about HIV. They're primed to think about it. We were kind of over-priming them. So we actually took that out, and now we just list HIV status as one of the many things that they might consider when they're answering the questions. We also added an item about potential family mistreatment to the anticipated scale. And this is something that came up in interviews with people living with HIV, but of course could be applicable across multiple forms of stigma. And then we reworded the very badly worded item about having people avoid touching you, because some people want people to avoid touching them, especially we were collecting data during the height of the COVID pandemic. So now it says avoid physical contact or being near you. Of course, I don't have results to share with you yet because we are just about to finish survey data collection, but we expect to be publishing updated versions of the measures sometime in the next year. Finally, I'll just really briefly speak about next steps for our team's work. In addition to finishing that work, really, for me, moving to think about structural intersectionality. And people like Patricia Homan have been doing a lot of work, both conceptually, but also methodologically on advancing this area. And in the context of HIV, been thinking a lot about all of these sort of conceptual or theoretical pieces that have been put out, arguing that structural stigma and discrimination are fundamental drivers of the HIV epidemic in the US. And while we increasingly recognize that, we do very little to actually measure it. There was a recent systematic scoping review highlighted here in AIDS and Behavior on conceptualization and operationalization of structural racism in US HIV research. And I think they found 10 quantitative articles. And all of those articles focused on measures of anti-Black racism. In thinking about Latina populations who are also affected by structural race, structural stigma and discrimination, and disproportionately impacted by HIV, there are no available measures related to any health outcomes focused on structural stigma and discrimination for Latina populations, except for measures focused on immigration policy. And so this kind of realization with me and members of our team led to this brand new R01. My co-PI is Ana Maria Del Rio Gonzalez, who's at the George Washington University. This was just funded in September, although we're actually getting started now. And what we are doing is developing, validating, and applying measures at the state level of structural stigma and discrimination, both for sexual and gender minority populations and for Latina populations. So in our first aim, we're going to use systematic reviews and modified Delphi panels to build consensus on the domains and constructs needed to capture these forms of structural stigma. We're then going to develop and validate indices at the state level for both of these measures. And then in our third aim, this is the exciting part for me, taking a structural intersectionality lens to look at the impact of both forms of structural stigma in combination on HIV prevention and treatment outcomes among Latina sexual minority men and trans people using data from the American Men's Internet Survey and from the US Trans Survey. And just shout out to our other team members, Jesus Ramirez Valles, Morgan Philbin, Kim Blankenship, and Jackie John, all pictured here. So more from that will be coming out in the next few years. I want to leave lots of time for discussion and questions, so I will leave it there, and thank you so much.